Good morning, everybody. Thank you for hopping on with us. I apologize for the late send out. So I am recording this presentation and I will upload it to our YouTube channel so that everybody can access it. If you weren't able to hop on this morning, I know I've already had a few people reach out to me. So I will go ahead and upload it and give everybody the link. As always, there is an evaluation at the end if you would like CE credit. I will get everybody's certificate distributed out to them in the next day or so. But without any more delay, I'm going to turn it over to Jamie Allaire. She's got a wonderful presentation for us this morning. And I thank you all for joining us again. If you need anything, don't hesitate to hop in the chat or reach out to me. Thank you, guys.
Hey everyone, my name is Jamie, like Kelsey said. We're going to talk about pediatric home safety and child abuse. April is Abuse Awareness Month if you don't know about it. So I just wanted to take a little bit of time to talk about a couple of things with summer coming up. Trauma is going to be a little bit heavier with some preventable things, so I thought we would have a conversation about that. I have been in the ER for the last 5 years. I started my career in pediatrics and PICU, and then transitioned to adult ER and then pediatric ER. Now I'm the PD educator. So if at any point during the presentation you guys have questions or you want me to stop, please let me know, pop in, raise your hand. I'll try to check the chat on my phone. It's just kind of hard to go back and forth. So we're going to start off with water safety. With summer coming, water related injuries are kind of big. There's a lot of accidental water injuries that occur. So I like to start off with some facts and myths when it comes to water injuries. So drowning is one of the leading causes of preventable death in children ages 1 to 14 in the United States, which seems kind of crazy because we have so many safety mechanisms. We have, so much talking and teaching to let drowning be a leading cause of death. I think is really a big deal. I think we've got to do something about it. One of the myths is children can only drown in deep bodies of water. It only takes a couple of inches for children to drown. They can trip and fall, or be in the bathtub, or be in the kitchen sink, and they can have injuries related to drowning. Another myth is drowning is noisy and easily spotted by parents or lifeguards. It's also not true. Drowning is very quiet. There's not usually a lot of splashing. There's not usually a lot of sound at all. Most of the time they slip under the water and it's so quiet that you don't even know that it's happening. And so the fact related to that myth is we should be careful and use water safety practices in any type of water, whether deep or shallow. And then the other myth is drowning takes a long time. Drowning can actually occur in seconds. If you're distracted by reading and replying to a text, somebody could be drowning. And so um, I have a little story here. It's kind of off topic. It is about drowning, but it's in my personal life. So several years ago, before I was deep into nursing, I'd only been a nurse for a couple of years. My kids were still pretty small. We were at a function with some friends, and we were in the water with the kids. There was two adults and then eight children. And so we're swimming, we're, talking, laughing. We're sitting there watching the kids. And every few minutes we were kind of both parents were doing counts, checking on the kids. Well, the next thing I know, I had just done a count, talking, and I look back and I don't see one of my kids. And of course I start freaking out. And I realized she had stepped off. She had been on the steps because she was too small. She was in not really a approved safety vest. She was just in little floaties, but she had slipped off of the step and was under the water. It was only seconds and she was okay, but the panic it ensued in me because I also had the misconception that drowning is very loud and that I would know, and it only took me couple of seconds of being mildly distracted with conversation for her to slip under the water. These are two water safety little flyers. I think they're really cool because it's going to sum up kind of what we should be teaching related to water safety. The American Red Cross has this awesome program. It's called Whale Tales, which is why there's the little whale on it. And it's a whole safety program related to water. But these are just a couple little steps. Looking before you leap, walking, not running, making sure that jackets are in place at all times, using safety on diving boards, staying within reach, not drinking or using drugs within the water, and always jumping in feet first, like no diving. So, like I referenced before, the American Red Cross has that whale's tail. That stands for Water Habits Are Learned Early. It is actually a really cool program, and it's not just for like healthcare professionals, it's for anybody, and really anyone can teach it. It's a really, really cool safety program. But I've kind of summed up here a little bit about what they discuss. So when we're talking about prevention of water safety injuries, we should be ensuring that children understand to ask permission before going in water or around bodies of water. Some of the circumstances surrounding drowning are usually accidental. Um, it's you're at a family gathering and the child wanders off, or things like that. And so, teaching children ahead of time to ask permission before they go in will decrease the risk of those accidental injuries. Avoid distractions like cell phones, making sure that somebody is actually supervising the kids. Coast Guard approved life vests are really, really important. They also should be properly fitted with the patient's weight. So making sure that the vest fits appropriately, is secured appropriately, so that it can do its job. When we're having like pools in the house or the backyard, ensuring they're fenced, and that includes spas because like your hot tubs and stuff are a drowning risk as well, and any other bodies of water to prevent unintended access. Don't dive into any body of water without verifying its depth. A lot of the spinal cord injuries related to diving are into bodies of water that seem deep and are very shallow. And teaching kids, especially older ones, don't push or shove other people into unknown bodies of water. There have been many, many accidents related to somebody being pushed off or into something and going head first and jamming their neck and causing a spinal cord injury. Always swim in areas with lifeguards present, whether that is true trained lifeguards or if that's family or guardians watching the children. Swim with a buddy. Don't use alcohol or drugs, and then making sure there's safety and survival skills like CPR and first aid training. When we're talking about water competency and water smarts, we've got to recognize our limitations. That means knowing your medical abilities, knowing if you have medical conditions that could impair your safety to observe or safety to swim. Diabetic, knowing a child is diabetic, and having those rescue medications if that occurs, and being able to keep a closer eye on that patient while they're swimming. Knowing how well they can swim. Just because a child can swim well doesn't mean they don't need a life jacket, especially in bodies of water like oceans and places like that, where it's very easily to get swept away. Again, find a buddy, not let them swim alone. Use U.S. Coast Guard life jackets, regardless of skill in most bodies of water, all bodies of water. Swim sober, know who and how to call for help. There's also something that they refer to quite a bit, and it's hyperventilation and a hypoxic blackout. So when people start to panic, they begin to breathe really hard and they start to hyperventilate. Well, that leads your brain into thinking something is wrong. And so there's this thing called hypoxic blackout. And so when you've hypervented for so long, then the patient actually goes into a full, like, unresponsive blackout, which then, if they're not wearing the appropriate life vest or they're not being watched appropriately, can lead into further drowning. And then understand your environment, the current and of the water. Like, you never know when, a tide or something is going to pull you under. And if nobody's watching, then nobody may know. The temperature of the water. Really cold water can shock the body and cause really significant issues, whether it's shallow and deep. And then there's other hazards like animals, plants, all of those things in different bodies of water that aren't just like your standard pool that can contribute to drowning. When we're talking about swimmer safety, there's a couple of things that we can do to kind of help prevent some preventable things. So ensure water that's over or enter the water that's over your head and return to the surface. So making sure that you can touch and resurface, or the child can. Float in, seeing if they can float or tread water for a minute, at least a minute, and then being able to turn over and around in the water. This is to ensure that nothing is going to be under the water to catch your feet. Swimming 25 yards and then being able to appropriately exit the water. So knowing where the exits are and how to get out if you get into trouble. In an emergency, we should teach parents and families how to recognize a swimmer in distress. So again, most of the time drowning is quiet. So this is swimmers with no forward progress. They're in the same stationary place. They're not able to move to one side or the other, or they're not able to appropriately find an exit. They're up vertical in the water, but they're unable to tread water. So most of the time, this is the patients that are bobbing in and out of the water, whether they can or can't reach. Usually you'll see their head come up for a second and then it'll go back under. The problem with this is a very short amount of time. If it is not recognized quickly, sometimes it's past the point of recovery in this drowning phase, and this is where they become unresponsive under the water because they can only do that for so long without taking a breath. And then it being motionless or face down in the water. I think a misconception with drowning is that when patients drown, they float, and that is not true. A lot of the time when a patient is drowning, they float or they sink to the bottom of the pool. And so when you're worried about a missing child or you're doing this sweep to find a child, you should be visibly looking in the water and underneath the water. So if it's a pool, you should be looking at the bottom of the pool versus on the top surface of the pool. If there's a lifeguard present, let them know. Let them know that you're searching for a child. Get all hands on deck. Get people looking in the water, around the water, in the bathrooms, in the house, wherever you are. Don't put yourself in danger. Provide rescue if able and utilize flotation devices for assistance. The problem with people when they're drowning, when they're in the process of drowning, is they panic. And so you don't want to put yourself at risk for drowning yourself because you're trying to save somebody else. So it has to be safe. Like we have to teach them to safely rescue somebody, utilizing those lifeguards. They've been trained to do that. They have the flotation devices. And so to be able to provide that rescue is really helpful. And then notifying 911. If it's a single rescue person, provide 2 minutes of the rescue, CPR, rescue breaths, whatever it is that you need, and then call for help. If there's other people around, making sure everybody has a role. So somebody's notifying 911, somebody's providing care for the patient. And then if you're in a place like a public pool or something like that where you can use an AED, get it out, utilize it appropriately. I wanted to include this slide because the American Red Cross has so many resources for like your average patient. So they have a first aid class, they have, CPR, lifeguards, swimming, water rules. This whole Whales Tales program is on there. And so it's a really good resource to provide to families, guardians, even just your friends and family, because there are so many things that even if it's just one little tip or one little thing that gives them the confidence at home to watch their children and other children around them safely. It's a really great opportunity. And most of it is free. Like the Whales Tales program, there's course modules, teacher modules that you can actually provide a course and then teaching to other people just through the class. You don't have to pay for it. You have to pay for some of the extra stuff, but not the modules itself. Next is medication safety. So I love this little algorithm because it really talks about like the standards of medication safety. So it says 5 children are rushed to the ER for poisoning, like medicational poisoning every hour. So it's because that's keeping medication in reach, or they're not in child-resistant packaging, like the lid isn't on appropriately. If you've ever had adult medication vials, if you turn it to one side, there's no safety. If you turn it to the other, then it's, of course, like, safety. It's really hard to get off. But for our grandparents or other elderly family members or friends, sometimes it's really difficult for them to get those safety lids off. And so they maybe won't put the lid on or they won't put it on appropriately. And so that can happen. Kids will climb, they'll reach and explore, and you think that you've put it out of reach, but they see you get it and they get interested. And then the next thing you know, they're climbed up on the cabinet, they have your meds out of the cabinet, and they've taken them. And then another thing it's really hard as a pediatric nurse to hear is people calling medication candy. When we tell them it's candy and tell them it's something good, the children are of course going to go back and want that again and again and again. So when we're talking about medication safety, these are just a few examples of accidental ways that kids can get medication. So finding medications in the parent's purse, and accidentally swallowing a tablet from the organizer, um, having vitamins that look like gummies and eating extra when the parents aren't watching. Eye drops. This is a huge one, and it's something that we don't think about, but eye drops on the bedside. on the bedside table. You would think that kids like don't eat or drink something that for you and I as an adult it would taste gross, but they do. I've seen a patient drink tiki torch fluid as a kid because they thought it tasted well. Accidentally tossing expired medications and then the child pulling it out. Getting too high or too many doses from people that don't know what the dose should be, and then maybe not closing a pill bottle appropriately. So, accidental ingestion is a frequent cause for an ER visit. This is things like Tylenol and Motrin, but it also is prescribed medications, metformin, glipizide, or sorry, no, all of their hypertensive medications. I was trying to think of, we had one recently that was a pretty significant medication. I can't think of what it was. But other non-medications like weed or drug paraphernalia. When a suspected ingestion presents to the ER, it's a pretty big deal because it's quite a extensive workup, especially if we don't know what they ingested. Sometimes the families say, "Well, I came in and they had a pill in their mouth that was dissolving." I don't know what that pill was. If they don't know what the pill was, then it's hard to know what kind of things and interventions that we need to provide. So most of the time, that patient is going to get a full lab draw, urine, all of the toxicology testing, but it turns into a pretty significant monitoring period over several hours to ensure that nothing is going to happen to the patient in that time. Because, as we know, medication onset isn't always fast. Sometimes it's over several hours, and sometimes it lasts, especially if it's an extended release tablet for hours and hours on end. So they can be hospitalized over several, hours or days related to a medication injury. So when we're talking about medication safety and what we can do in the ER, we should provide significant education on just preventable things. So like using these medication lock boxes. These are like 18 or $19 on Amazon. They have a little code that you have to know, and they're super easy to open. But there's other things like don't call medication candy. In the ER, if I hear somebody say that, I actually stop them in that moment and say, hey, let's not do that. And I tell them why. I explain to them the significance of calling it candy and the risk that it poses to these patients if they think it's candy and it's actually medication, so that we can educate them in that moment and they don't continue moving forward. Kat actually tells a story about a call that she went on where the grandparents were putting the meds in the very top cabinet of the medicine cabinet, so like the very, very top. And I guess the kid had seen them persistently doing that, and the kid got a chair, got on top of the cabinet, and then got into these medications and had to be seen in the ER. But kids are so resilient. Like they are just so intrigued and interested in what they're seeing that they don't really know better. And so something else that's really, really important is to talk to and educate the kids on medications. So like in my personal practice with my kids, they know about my medications and we talk about how dangerous like they can be to them. And we talk about why I have to take them and why they stay put up and stuff like that. So that in the event that a random pill was out, I don't have to be concerned that even my son, who is 6, even when he was 4 or 5, I wasn't as concerned that he was going to pick up a pill and put it in his mouth because we do so like such in-depth and significant education regarding medication safety. And if these families haven't ever experienced it before, they don't know better. So it's our job as healthcare professionals to encourage them to do that. Currently in our EC, we have created a safety cabinet that has things like these medication boxes in it so that when this accidental exposure or ingestion occurs, we can provide them to the family to prevent that in the future. Poison control is a huge resource that we use, I'm sure throughout the hospital, but especially in the ER. When we have a family come in with any type of ingestion, we immediately call poison control and get their recommendations. But at home, there's actually several options now. So I think when my oldest was born, she's 13 now, but you really kind of had to call. Now they have an online option. So the families can click get help online, and they'll actually chat with them through a chat about the ingestion and give them recommendations. Um, Also, they do these little like tips of the day, if you can see it here. This is from a while ago because I took this whenever I made this presentation initially, but they'll give little like spring cleaning tips, like of getting rid of old medications, And it's not just medication related, it's ingestible substances like toilet bowl cleaner and stuff like that. And they also have a pill identifier. So if a family is moved into a house and they find medication in their home, they can actually identify the pill and be able to appropriately dispose of it. But it also does like batteries, everything. So it's a really good resource. It's a really cool like website if you haven't been on it in a while. Next is helmeting. So the impact of helmets is really, really, really large. Patients that present with head injuries after being unhelmeted are pretty significant, and it can be as bad as just a severe brain injury or death. I actually read several story or studies, and I thought it was very interesting that they report that up to a 40 to 45% reduction in fatal brain injury just related to a helmet. And it doesn't mean that the patient didn't have significant injuries like broken bones, internal bleeding, but talking about like your brain itself, like what makes you who you are, protecting that and reducing fatal brain injuries was pretty significant. Helmets obviously absorb that impact, but they also help with internal and external injuries to the face and head. So we're talking about like lacerations, skull fractures, traumatic brain injuries, and not like, I mean, all of that is related to like helmeting. Depending on the helmet, especially those like visor ones, when you're talking about like ATV, UTV, um, dirt bike, all of that stuff. They can protect your face and ears from debris or other environmental factors like tree branches, rocks, all of those things. And then bright colored helmets increase the visibility to others around the child. So, like if they're riding a bike and they have a bright yellow helmet on, it's going to be a lot easier for the person that's driving to be able to see that patient. So, like I said, there's lots of things that we should be helmeting for, but this is even as simple as like bicycles, scooters. We've had quite a few injuries related to just accidents. As parents, as healthcare providers, we should consistently discuss the dangers of lack of helmeting. I think providing real life stories, real life examples are really beneficial because then they understand the impact. Whenever you're a child and you have this helmet and it's uncomfortable and it pinches and it this or that and you don't want to wear it, when you understand why we wear it and what it prevents, it's a lot easier to get behind it. As an adult, whenever you get a new directive or whatever and you don't know why, it's a lot harder to follow it than it is to know when you know the impact of what it's happening or what the reason for behind it is. Investing in a high quality helmet that fits appropriately is also important. It should be snug fitting to the patient's head but not too tight, and there should be adequate ventilation in it. Parents and guardians should also be encouraged to model the appropriate behavior. If you are riding your motorcycle and you don't have a helmet on, your child, your grandchild, your family, your friend is going to model the same behavior as you. So as healthcare professionals, most of the time when patients are presenting with these severe injuries after an unhelmeted accident, it feels like it's too late to do the education, but it's not. It's our job and our duty to ensure that they understand how important it is moving forward to prevent the same type of injuries just by like wearing a simple helmet. There are other protective equipment that we should be using whenever, riding ATVs like long sleeves or motorcycles, pants, boots, gloves, but when we're talking about protecting our head, helmet is really, really important. Whenever these patients present with like minor accidents or injuries, so like let's say they fell off their electric scooter and they have a laceration to their forehead, this is the perfect time to be able to discuss how important a helmet is and how easy it is to obtain a helmet to prevent those future injuries. In the EC, like I mentioned a second ago, we have our safety cabinet, and Dr. Bargava worked really, really hard on getting supplies down here. But helmets are another one of the supplies. So we have things like gun locks, medication, safety boxes, thermometers, helmets, so that we can provide those real time in the moment and do the education surrounding it to prevent further injuries like this. Next, we're going to move into child abuse and CPS. Moving into summer, moving into April being Child Abuse Awareness Month. Child abuse is it's a hard topic to discuss, but it's so, so important. These kids don't really have a voice, and so it's hard whenever, as adults, like if we're not paying attention and we're not watching out for them, it's hard for them to be able to speak up for themselves. So these are just a few statistics. I'm not going to read them all, but child abuse is so effective to kids. Like it affects them not only in that moment, but it affects them for the rest of their life. And you can see here, these numbers are astounding. The amount of children, worldwide that are being abused is just astronomical. It's actually appalling to see because we live in 2025. Like, we have got to do better for our kids. And so the way we do better is we talk about it. We bring it out in the open. We educate and make sure that we understand what we should be looking for so that we can see it, stop it, prevent it. But as you can see in the lower right corner, look at all the things that occur to these kids whenever they're abused. Anxiety, depression, PTSD, behavioral things like substance abuse. Like, we don't, I mean, and of course, like, other type of health related things because they're scared and they have all of this related to this. But this is things that we can prevent. So, and talking about it is really important. It's deadly and it's costly to our society because of the impact that it takes on the children and our caregivers. Um, Most children are abused by a parent, which is also really sad and disheartening because as parents we should be taking care of our kids. And then a lot of cases abuse or involve child sexual abuse, and that's also difficult to hear. When we're talking about pediatric assessment and screening, there's many types of abuse. So there's like our physical abuse, neglect, sexual, accidental injuries, and then appropriate ingestion. So not every injury is going to need CPS. So your patient falls from playground equipment. Absolutely, that's an accident. But your patient comes in with fingerprint bruising on the upper arm and they're on their third fracture, that's abuse. And so we have to know all of the different types of abuse to be able to recognize signs and symptoms and move forward with what that looks like. So I do want to point out that when we're talking about neglect, neglect is very difficult to recognize sometimes because when we think of neglect, we think about like your disheveled child or your disheveled patient that comes in and they're like super dirty and they don't have a, good living arrangement. But this could be something as simple as an emaciated patient that doesn't have access to food or doesn't have access to everyday needs like shelter. So for example, a patient that's found wandering outside their home without a caregiver present, that's still neglect. Whether they're fed or not, that is neglectful. Now, in that same sense, there's accidents where the mom is in the kitchen, she's super busy, or the dad, and the patient opens the back door and runs out. That's different. Like, this is it's very difficult to determine sometimes, like, what. But an inappropriate ingestions is also another big thing because if you see here, these little candies, that third picture, they look good. They look like gummies or like vitamins or the little mushy gummies that kids eat. And so it's very easy for a child to accidentally get into something like weed and not know about it or not know any better because it looks like candy. And so it's really important to make sure that those are put up and keep the patient safe. So when we're talking about non-accidental trauma screening, and I know that word is really hard for some people because we're talking about child abuse here, but it is just one of the medical terms to describe. It's often referred to as NAT or non-accidental trauma, in related to CPS and injury screening. So when we're talking about the word trauma, a trauma mechanism is not required to perform any type of injury screening. So, because abuse and neglect and ingestion can all occur without like an actual trauma mechanism. So even if the patient doesn't come in with an injury related to trauma, we are still going to screen them and then we're going to document it appropriately. We target patients less than or equal to 5 just because that is a really high risk population. They don't have the ability to speak up for themselves. It's kind of hard to get them to be believed, quote unquote, because of their age or because of how they describe things. And that population doesn't really know the difference between right or wrong. Like, they just trust everybody at that point, which is why we talk about stranger danger and things like that, because they don't know who not to trust. And so we have to be really, really vigilant in screening that age for these injuries and ingestion. So when we're talking about screening in RER, we look for patients that are less than or equal to 5. Did an injury or ingestion incur? And then if both of those answers are yes, then we immediately move into our like non-accidental trauma screening. So this screening is very standardized questions that can be asked to any parent or be assessed on any patient to look for unexplained injury, an inconsistent story, or an inappropriate injury for age. It also does like neglect and things like that, but kind of this is what the basis of it is, and then determine if a potential CPS referral is needed. So I do want to point out that even an accidental injury can sometimes require CPS. So if you have a patient that presents to the ER unhelmeted after a significant accident, although that was an accident and the family might not have known better, that is still something that is reportable to CPS. If you have a patient that presents in an MVC after not being properly restrained in a car seat, although again, that was not intentional, it is still reportable to CPS because it is endangering the patient. So I do want to point out though, again, suspected abuse, neglect, ingestion, whatever, I don't care what the patient's age is. If you suspect that something is happening, we should still be documenting it and reporting it appropriately. In our system, we have a whole little ad hoc form so that it can be, performed on any patient, not just the ones that are under 5. So this is what our screening looks like. In our patient history, in our triage note. So all of these different boxes and all of these different agencies will prompt this screening to be performed on these patients. We also have to have a downtime form that fits very, very closely with our like Cerner form. But as you can see, pretty standard questions. There are some times when there is not a family or a guardian present to answer these questions. And on those specific patients, it's at the nurse's discretion to be able to determine if CPS is needed or not needed. If there is ever a time that there is any signs, signals, things that are said that you doubt the patient's safety, they should be notified regardless. It's not our job to investigate, it's our job to report appropriately. So when we're considering abuse and neglect, a big question to ask is, does the injury match the developmental age of the child? So if a patient presents with their 2-week-old and says they roll off the bed, can they really roll off the bed at that age? Um, no, they can't. And so that should already be high suspicion. If the story consistently changes, so they tell the triage nurse one thing and then they tell the physician a different thing, and then you come back and they tell you something, and then you do your rescreening an hour later and they tell you something else, like that is very significant. Like that should be, bringing red flags in your brain. If they're injury blaming on younger or older children. Now, if you have older and younger children, you know that sometimes injuries do occur. But let's say you bring your 2-week-old in and the parent comes in as like the 2-year-old dropped them, but the baby has bilateral subdurals, skull fractures, retinal hemorrhages. Like you should know and you should be suspicious that this is probably not an injury related to their 2-year-old. And then is the parent or patient and caregiver relationship appropriate? So does the patient cry when the parent is in the room? Are they withdrawn or do they not act appropriately to like painful procedures? So like let's say we're going to start an IV and the patient just kind of zones out and they don't cry or anything. Those are all other suspicions. So when we're assessing for injuries in pediatric patients, we should be asking age appropriate questions. Don't lead the patient. Make sure that the questions are open-ended. So yes, no questions are okay, but like for certain things, but asking them questions where they can elaborate and they can say what they want is a lot better. Ask about the injury several times. Like I said, if the story is not true or if there is embellishments in the story, it's going to change and you're going to find holes in that. If you're alone with the patient or if you have the opportunity to ask the parent or family to step out, this gives the patient the opportunity to share without fear of retaliation from their abuser. Let the child know that they're not in trouble. We're not upset with them. We are here to help them. We are here to protect them. But don't make promises you can't keep. Don't say you'll never go back to that home whenever you don't know. That's again that's what we want. I never want you to ever go back to your abusive household. But sometimes the system is broken and we can't make promises like that we can't keep. And then don't leave the
I think
patient
it's about child
alone.
abuse. Yeah, it was. I forwarded it to PD.
Hey, somebody is unmuted. Would you mind muting yourself, please? Sorry, I can't talk over you. Thank you. Sorry about that. Um, Utilize a sitter or get somebody like a tech or another nurse to be able to sit with the patient until you can ensure that the patient is safe and check on them very frequently. Keep the door open. These patients are at really high risk of eloping, or especially if they think that we're suspicious of them, waiting till you're not paying attention and picking up their patient and leaving. So when we're talking about screening and assessment, have two nurses or a nurse and a physician to be present. That way you're not alone when you're performing these assessments. Remove all clothing, head wraps, bows, place a patient in the gown, and then make sure that we're taking photos. So don't just start cleaning them up until you have like photos and stuff like that so that CPS has all of the information when they present. And make sure that we're assessing them head to toe. That includes like oral mucosa, ears, bottoms of the feet, the peri area. Also ask the family prior to the assessment or during the assessment, because most of the time they're present, if they have any type of like birthmarks or any areas that they've had present since birth, so that you know. Most of the time, those areas like Mongolian spots or birthmarks can be validated by the PCP in like prior notes or prior medical visits, like urgent care or whatever. So that's easily verifiable. Palpate the head. We're looking for like bogginess, injuries, hematomas, and then always assess a head circumference in these patients, especially in those patients less than 2 years of age, because in the head's going to grow. And so if you notice a 2 or 3 centimeter difference within an hour or two, like yeah, we should know that that's something we should be very cautious about. And then looking for any other injuries. Make sure that that's documented oh gosh, photographed, and placed in the patient's chart, and then notifying the provider if they're not present in the room with you. These are just a couple of things that are very easily like mistaken for abuse, but are related to, things that are outside of the patient's control. So Mongolian spots, which you can see in the first picture and the third picture at the bottom. These are like purplish brownish looking bruises. And as you can see, they look like bruises. But don't take them as Mongolian spots unless there's documentation or a history from the family. There has been a couple of times where we have suspected abuse and it has turned out to be Mongolian spots, but we would rather be way more cautious and careful than assume it is something like that and miss something significant like abuse. The two pictures and the second picture and the fourth picture are stork bites. Patients are born with these. These are like birthmarks, but they can be mistaken easily for bruising. And then one of the last, like, really important things I want to talk about when it comes to these things is osteogenesis imperfecta. So the characteristic of that is blue or gray sclera. If we have a patient that is presenting with multiple broken bones, one of the first questions I personally ask are, what does their sclera look like? Because if they have this bluish gray tint in their sclera, we should be very suspicious of osteogenesis imperfecta. These patients are going to have multiple visits for broken bones. And if they haven't caught it early when the child is small, which they usually do, it may be an abuse type situation that the parent is being accused of, when in reality the patient has a significant medical issue that causes brittle bone. And this picture, as you can see, is very, very significant. I will say that not all osteogenesis imperfecta presents that good. So this is a great picture, but it's also often a lot more subtle than that. So persistent vomiting is one thing I want to discuss in abuse patients, because especially if they have a lot of a blunt trauma to the abdomen, they're going to have vomiting, but they're not going to have things like fever or diarrhea or runny nose. Like, it's going to be significant, like vomiting. Bloody sputum with or without a cough is always significant. Those patients should be thoroughly assessed, because you can have things like pacifier injuries, injuries of related to like sticking fingers down their throat and stuff like that. You can't see if we don't perform a good assessment. So when we're talking about bloody sputum, we should ask the patient, have you had a nosebleed within the last 2 hours? Have you had a nosebleed within the last 24 hours? If either one of those questions is yes, then of course the significance of bloody sputum is less. But if there is not a reason for that, be very suspicious. And then ER hopping recurrent visits for the same complaint. That's like being seen at multiple hospitals for the same complaint or similar complaints without staying consistent because they don't want people to suspect that there's any type of abuse. In our older children, there's unexplained behaviors and changes of personality, becoming withdrawn, anxious, aggressive, lacking social skills, not having friends. They don't have a relationship with their parents, or they know way too many adult things. And as our population grows and social media becomes a thing, like kids smaller and smaller begin to know things that they shouldn't, right? They know adult things or they say adult things that they shouldn't. But we're talking about like significant things that kids shouldn't know. And then running away or going missing or always wearing inappropriate clothing for weather. So like let's say they're wearing a turtleneck with a jacket and multiple pants and socks. Now, some kids just do that. You see patients or people in hoodies all year round, and then you see people in shorts all year round. So it's more than just that, but that is one of them. Other things are delay in seeking medical attention, driving really far from home to seek care, um, going hospital for different injuries, being super defensive, eloping, asking to sign out AMA, asking to be transferred, missing scheduled appointments, or not meeting milestones. I will say these patients are so high risk to elope or to ask to sign out AMA. And honestly, the hard part about that is there's nothing we can do. The parent retains their right until CPS comes in and is willing to take the patient if that's necessary. But the parents have all the same rights. If they leave before appropriate medical care can be provided, we can always call the cops and ask them to go do a welfare check, and CPS will usually make them come back, but we can't hold them against their will. 10-4 faces with the P at the end is a easy thing to remember when it comes to assessing for child abuse. This is taught in TNCC, ENPC, kind of all the things, so that you're looking at the areas and bruising on patients that are younger than 4. So these are just a couple of symptoms. I say a couple, I know it's a lot, but some of the really important ones. So persistent crying is a big one. Lethargy, listlessness, bruising in different stages of healing, enlarged head circumference, choking episodes, new onset seizure activity that, especially if they report seizure activity that's been occurring over several months with no intervention, assessment, or treatment by a physician, failure to thrive, rapid weight loss, and then poor feeding or inability to PO feed. It is really important when we're talking about inability to feed or difficulty feeding, asking the parents how they're preparing the formula because um, sometimes parents, formula is really expensive. I haven't bought it in a while, but when I walked past it in Walmart the other day, I was shocked at how expensive it is. But they need to make it go further because they're worried about money or funds, and so they improperly dilute the formula, and then this can cause electrolyte changes and can cause seizures and other things. It's not intentional. They're not trying to abuse their child, but it can cause really significant issues in the patient's brain. So bruising, contusions, and tissue injuries. This is why it's really important to remove clothing and diapers and headbands and hats and everything the patient has, because in some of these areas, they're not areas that you're going to be looking for standard on a pediatric patient. So the backs of the ears, the frenulum, they can have a torn frenulum in their upper lip and underneath their tongue. Usually that's from trying to shove the pacifier or a bottle in their mouth too hard. And then the bottoms of the feet on a newborn. And then if you can see that far left picture, that's called fingerprint bruising. And it's where somebody has grabbed that patient and you can see the outlines of their fingerprints. If the patient presents with a vague presentation and there's no explanation, you should be very suspicious. The patient may be limp or pale. They'll have this petechiae, like you can see on this patient's eye and the neck. That can be as simple as like the patient has been coughing too hard, but it's going to depend on the situation. I'm not saying every time you see petechiae on the eyes and the face, it means that the patient is being abused, but it is very suspicious, and so you should be suspicious. If the patient has a hoarse voice, if they're apneic or they have adventitious breath sounds, really significant pain or bleeding from different areas, they can't move the extremity, thigh swelling, they have significant bite marks or multiple fractures or injuries, those are all really high suspicion. These images are so hard to look at because you think like who could ever do this to a child? But anytime you have circumferential burns, it is never less than abuse. Like you should be suspicious. I'm not saying well, I am saying there is rarely a time that that you have circumferential bruising or burns like this that the patient is not being abused because if you can tell there is no splashing, there are no splash marks, and it's because the patient has been held down in these areas, which has caused the burns to be so significant. So there is never a time if you see things like this that we shouldn't report abuse. And head trauma. Head trauma is probably the behind like arm, leg, rib fractures. Head trauma is one of the biggest things we see in pediatric abuse. And these are just some signs and symptoms of it. This is one reason that doing a head circumference on all of these potential abuse patients is really important. Um, Poor feeding and inability to tolerate PO are probably what we see the most when it comes to this, but irritability is really, really high too. When we're looking at these patients that have been shaken or have received this significant head trauma, we'll often see retinal hemorrhaging related to like the brain injury. So we should take these pretty seriously. I wanted to include, this is my son when he was a little bit younger, but I wanted to include two different types of C-collars because when we're talking about head injuries and these small patients, especially like your 2 week old, your 2 month old, they're very small. And so finding a C-collar that's actually small enough for those patients is very hard. We had double zeros at one point, and even that on these teeny tiny patients was causing some hyperextension of the neck. And so we don't want to cause further injury. So when we're measuring for a standard C-collar, this is a DJO brand, but there's all brands kind of have some type of device or weight color measurement to go off of. But this is how to properly measure a patient to ensure that the C-collar fits appropriately. And so you could see when you're measuring, like on my son, on the bottom of his chin would be yellow, so that would be the appropriate C-collar size for him. When you're talking about a blanket C-collar, it's actually really stable and really fantastic because when these patients, like we have these traumatic injuries and the patient is crying, we still want the parent to be able to console them. And so this type of C-collar is really good because the parent can still hold them. They can still be swaddled around it so they can receive comfort like that. But you just fold it in about a 2 to 3 inch strip, I guess, and then you slide it underneath. Somebody's still maintaining C-spine, you slide it underneath the patient's neck, and then it can be wrapped around. Log roll the patient when you're doing your posterior assessment, and then you can secure it if you'd like to ensure that it stays there. One thing I don't recommend and I don't like is when we tape to liter NS bags or LR bags to the patient's head because at some point that has to come off. And although, yes, it's kind of helping when the patient is small, they can still move their head a significant amount. And that is just taped across their skin, across their neck, or wherever. And so it can lead to other things like skin breakdown, and you have to take it off, and it just hurts. When we're referring to, or when we're talking about CPS referral, it's you have to determine how fast or when you need CPS to come. So if there's suspicion or abuse, you need to determine emergent or urgent. So there's two different. So emergent means the patient cannot go home with the parent. There's multiple fractures. The patient is in significant danger, and I need CPS here now. So if you're at an outside facility, you're going to call and contact the local police department, let them know that an emergent CPS case is needed. CPS is still going to ask you to file an online report or like a phone report so that they can have the details a little bit better than what the police can provide. But this will get CPS to bedside immediately. If it's urgent but not emergent, the patient was at risk or there was a safety concern, but the patient is still safe to leave, then you can do it online or on the phone. Because you're not going to get the same response. Filing online and over the phone alone is not going to get a caseworker to come to the facility. You need law enforcement and yourself to notify them so that they can get there more quickly. At UMC specifically, some of our police officers can help with this. They can help notify CPS for us. But if there's ever a situation where they're not sure or they say they can't do it, we can just call LPD and they'll come and assist at any point. This is just a couple of like extra things when it comes to CPS referral. So if a child is unrestrained, I mentioned this earlier, they're not in a car seat or they're in an appropriate seat in the car, like the front seat, a 2-year-old in the front seat, we still have to notify CPS, even if somebody, the parent, a family member, whatever, is killed in the wreck. Because this is not only impairing this, that the patient safety has already been impaired. They have been in a significant accident without a car seat. And so it's not that we want them to get in trouble, but CPS needs to intervene and give them the resources that they need. Please know in these patients in these situations, we should never send a patient home without a car seat. At UMC, we have many resources to get the patient a car seat before they leave, and we want them to be as safe as possible, especially if the reason they weren't in a car seat is because of funds. Um, uh, the last two things is talking about online versus like immediate CPS case needed. So the patient was in an NVC, they didn't have a car seat. We filed the report online, but we don't need somebody there. We've discharged them, we've done the appropriate education. They're safe to follow up with them outpatient to make sure that they have the resources they need, and then they'll close the case. If you have a 4-month-old with bilateral femur fractures, we know that CPS is needed now. That patient is presumed to be in immediate danger. Somebody has harmed this patient or something significant has occurred. We need to get the police department involved to get CPS here as soon as possible. There's many ways to file. So you can file by going to the Texas Department of Family and Protective Services website. There's a big red thing that says report abuse. It gives you the phone number and the Texas abuse hotline. If you're not sure, there's the frequently asked questions or FAQ section that you can read. In our Cerner system at UMC, it also provides the number right there for you. So if you don't know it off the top of your head, you can provide it. You can, or you will create a report when you make or I'm sorry, you will create an account when you make an online report, and they will actually mail you. It doesn't say anything significant about the family or the patient, but if they close the case, they will mail you a case closure. Another significant thing is when CPS removes a kid, there's been quite a few changes over the last like little bit in like legislation and stuff related to this. So when CPS is going to remove a patient, they have to have an injunction or a court order unless the family is willing to sign over their rights to the family, or I mean to CPS. So if CPS does their investigation, they determine the patient is not safe to stay home, then they're going to ask the family, we believe this is in the patient's best interest to remove them from your custody. Do you sign over and do you agree to give us permission? If the family says yes, it doesn't remove them from like liability or anything like that, but it gives CPS the opportunity to remove the child, place them into a safe home until we can either get the resources or whatever else the family needs. If the family says no, then the CPS has to go through their supervisors to get an actual court injunction from a judge to remove custody. It's very, very difficult, and it is especially hard after hours. If a removal is obtained, whether either way, by injunction or by family, you're going to get this notice of removal of children. I've obviously cut the document because I don't have a blank one and I didn't want to include patient information in it. But this is what it looks like. Where under case information would be all of the patient's case information, all the patient's information, people in the safety plan, people that aren't allowed to see the patient, whatever. This document must travel with the patient everywhere. If you're at an outside facility transferring the patient in, this document must go with the child. If you are in-house, like you're in UMC, the patient is going to radiology, to a procedure, to anywhere else, this document must transfer with the patient at all times so that everyone who is caring for this patient is aware of who has custody or appropriate custody of the child. Um, when we're talking about, this is kind of the last little bit of it, but when we're talking about CPS referral, I have just a few reminders. We are mandatory reporters as healthcare professionals. Our priority is keeping them safe. It is not our job to investigate. It is our job to report. So if there is suspicion, we don't have control over what happens next. So you don't have to feel questioning or responsible or anything else. Like your job it ends when care ends. So you have done your job. You have done your due diligence of providing the assessment, contacting the proper people, the proper authorities to ensure that that patient is safe. Again, we can't force families to stay in the ER. If they ask to leave, it is our job to notify law enforcement immediately, notify CPS, unless the child has already been removed from the parent's custody. So if there's a safety plan or the custody is removed and CPS has custody, then we can absolutely hold the child. It would be kidnapping and elopement if they stole the child once the patient has been removed. But prior to a safety plan, prior to removal of the child, we cannot force them to stay. If they decide to leave AMA, we can talk really, really hard to them, really explain why we're doing it, why we want to assess them, why we're scared for them to leave. But if they choose to leave, we immediately notify law enforcement and CPS, and they will go and do what they need to do. Your role is contacting CPS law enforcement. They'll perform that welfare check, and I'm going to say 99% of the time they're going to escort the patient back to the facility. And then the most important thing is document, document, document. Interactions, observations, education that you've performed, case numbers, photos, everything that you've seen, everything that you've done. Because if this case goes to court, and they subpoena you, then all you have is your documentation. Are you going to remember everything that happened 2 years ago? No. And so the more you document, the better you document, the more you're going to have should those patients or should you be called on in any of those situations. That is all I have. Thank you guys so much for listening. I know that child abuse is a really hard thing to discuss. It's a hard thing to hear, because we want what's best for our patients, but it's really important to have a conversation about and bring it to the forefront of our minds so we can do the proper screening. So I appreciate every one of you guys being here, and I'll turn it back over to Kelsey, unless there's questions or anything like that.
Thank you so much, Jamie. That was a wonderful presentation. All of this is recorded. I am about to press send right now on the evaluation form. If you would like 1 hour of CE credit, just fill out the evaluation and I will get you your certificate. If you think of any questions or need anything or have any suggestions, please feel free to email Jamie or me, and we are happy to help you out wherever we can. So if no one has any questions, then I will turn you guys loose for the day, and I hope everybody has a wonderful week and a happy Easter next week.